Welcome to the virtual conference facility at your Centers for Medicare and Medicaid Services. Hello, I'm Valerie Hart. This is where we use the power of our satellite networks to give busy healthcare professionals access to important conferences and meetings. Today's broadcast is available locally at Medicare carrier and fiscal intermediary sites over the CMS Satellite Learning Channel and at selected Indian and Tribal Health Service facilities on the CMS Indian Country Network.
Welcome to the Long-Term Care Educational Conference for Indian Country. This conference was held December 3rd and 4th, 2002, and sponsored by the Indian Health Service and your Centers for Medicare and Medicaid Services. Today's broadcast includes segments from the PACE and home and community-based waiver sessions.
This session's about to begin, so come on in. We've saved you a front row seat.
Good morning. I think we're now ready to start our second plenary session of the morning. We are going to be exploring the program of all-inclusive care for the elderly, or the PACE program. We have with us Sean Bloom, who is President and CEO of the National PACE Association. The National PACE Association is an organization that represents 36 PACE sites and 25 additional healthcare organizations in various stages of PACE site development. Prior to the National PACE Association, he served as Executive Director of the Missouri Association for Homes for the Aging and is also serving as the Principal Investigator for the PACE Expansion Initiative, which is a 3-year project funded by the Robert Wood Johnson Foundation and the John A. Hartford Foundation. From CMS, we have Melissa Harris. She has been working on PACE activities for the past several years. She participates in the development of national PACE policy, as well as reviews application for permanent provider status. She has provided technical assistance to numerous provider agencies and states looking to implement the PACE program.
I think the biggest fear in society across this country, regardless of cultural, ethnic, or religious status, is the desire to live in our homes as we age and need services. And one of the things I'm very excited to present to you about PACE today is the notion that this is truly the purpose of PACE. And I'll explain that more in detail, but the purpose of PACE at its core, simplest goal is to provide the opportunity for individuals that are nursing home eligible to remain living at home in the community and bring to bear all needed services in a cost-effective, common-sense approach so that that person can remain as healthy and as independent in the communities, vis-a-vis in their homes, as long as absolutely possible. Simply stated, what is PACE? And that's always simple to describe PACE in kind of really a very broad brushstroke approach. Again, PACE at its core goal is a program that's intended to allow individuals that are nursing home eligible, frail elderly, to remain living in the community for as long as absolutely possible. We do that through what I'll consider to be 4 broad objectives. One, it's community-based in the sense that we want to and are incented and honor the needs and wants of the individuals we serve by providing the greatest extent possible those services in the community at large. What does that mean? That means in the provision of services in individuals' homes. That means using significantly an adult day center as a focal point for the delivery and organization of those services. But at the end of the day, our incentives are aligned very closely with those individuals we serve, and that is to keep them out of the hospital and keep them out of the nursing home. And our ability to do that is in large part dictated by the quality of services and preventative interventions that we can provide. And if we do that, we win. If we do that, we honor the wishes and needs of the individuals that we serve. But we do that through a very focused community-based approach. We also do that in a very comprehensive fashion. Unlike a typical nursing home or unlike a typical home care agency, we're not just one stop along the kind of long-term care continuum. We are, as our name implies, all-inclusive. And what that means is that we are provided monies through Medicare and Medicaid not on a billable basis. We don't get paid every time we do something. We get paid up front on a monthly basis in a prospective way to provide all needed services regardless of what they may cost and regardless of whether they exceed the budget that has been provided to us. And it is clearly the incentive of the PACE program to do that in a very comprehensive way, bringing to bear the full range of services ranging from pharmaceuticals through homemaker chore. As I like to say, we're responsible from everything from toenail clippings to surgery in a hospital. And we will do whatever's necessary in the most common sense approach to do that, but that's done in a very comprehensive fashion. I alluded to or mentioned that the fourth objective of how we accomplish the goals in PACE are through capitation. Unlike fee-for-service, where if you provide a day of nursing home care, you provide a home care visit, you are paid in retrospect for what you did, we are paid in advance a flat sum per member per month up front with the commitment that we will provide all needed and necessary Medicare and Medicaid services to those individuals that we serve. And that is called capitation. And we must live within the risk payments associated with that capitation. And lastly, our services, and probably the most importantly in terms of the function of PACE, is that they're coordinated. And I'll talk in a minute about what that means, but in essence what it means is that PACE is coordinated through what I consider to be the heart of the PACE model, and that is the interdisciplinary team. These are not an individual that's sitting managing 400 people. It's a team of typically between 5 and 10 individuals that meet on a daily basis, that generally manage a group of frail elderly to the tune of about 150 people. And that team is typically comprised of nurses, doctors, social workers, dietitians, the person that picks them up in the van or a representative of the transportation staff, and literally every person that is responsible for fulfilling the needs of that person in some portion of their day or their life. And that is really key to PACE. Nursing homes will always be needed. They're always going to be important. But our hope, and I think in response to consumers' demands, they're going to be a smaller piece of the long-term care pie. To really appreciate PACE years ago, as they did, I think you must acknowledge that our typical healthcare system for the elderly is a very fragmented system. To the extent that you don't have the resources to kind of navigate your way through the system, you've got to rely on funding streams that are oftentimes very disparate and oftentimes not developed in tandem to work together, and that is Medicare and Medicaid. And a lot of our system is really, really focused heavily on an institutional bias. If you look at Medicare spending, I don't need to tell anybody here in the room that, you know, a vast, vast majority of dollars go for acute care settings, services provided in acute care settings. I think, as we like to say, to the extent that an individual in fee-for-service Medicare has a really bad episode in terms of a stroke or so on and so forth, our Medicare program is very, very good at paying for that. But what it is not intended to pay for are all those preventative services and things that may have allowed that individual to avoid that episode of care. Our system's also focused, specifically I think Medicare is extensively focused on the provision of acute care. There is a misnomer in the broader, I think, public here, the 65 and over, for that matter, society as a whole, that Medicare will pay for all your long-term care needs. Most of us here in the room know as professionals that it does not. It will pay for a short stay, institutional skilled stay, post-hospitalization under certain circumstances, but for all practical purposes, Medicare is not a payer of long-term care as we know it today. Medicaid is, but how do you qualify for Medicaid? You deplete your complete life-saving nest egg or rely on children or family members to pay. And lastly, going back to the comment about the lack of kind of coordination or integration between Medicare and Medicaid, there's not a lot of opportunities to integrate payments in the fee-for-service world to meet the needs of individuals outside of institutions. I'm not going to walk through every single policy step here in the interest of time, but in approximately mid-70s, there was a woman by the name of Mary Louise Ansack that was working on behalf of the Chinese American community in San Francisco, Chinatown, San Francisco. And they had an interest that was both culturally specific and I think geographically, or I'll call real estate constrained, in meeting the needs of the individuals, the older Chinese American individuals. To build a nursing home in Chinatown was not only inappropriate from a cultural standpoint, from a financial standpoint, it just didn't make sense. So what she began to realize is we may want to develop kind of a day center and bring these individuals to the day center and begin to try to find a way to meet their needs. Through a series of steps, she began to realize that only having one piece of that kind of proverbial healthcare funding pie was rather constraining. And through a series of steps and waivers and working with Congress, she was able to secure the ability to pull down dual capitated funding. And if you talk to her, she puts it in really simple terms, and she says, just give me the money up front. let me do what is in the best interest of the individual, whether it be buy an air conditioner for the window or flea dip a dog that has fleas to keep the person from being flea bitten in their home. Give me the money up front and let me be creative and common sense in my approach. And much to the credit of Congress, they allowed her to do that. After many years of replicating the model to try to test the notion that, or the question of, is this a model of care that's only specific to the Chinese American community and is only applicable in a really dense, urban, culturally specific area? They authorized the demonstration program, and there were 13 demonstration models that were developed throughout the United States, predominantly in metropolitan areas, admittedly. But today, all those programs currently exist, and I think in the Balanced Budget Act of 1997, Congress, I think, it agreed with us that this is a model of care that may be more widely applicable beyond Chinatown. In 1999, the regulation was implemented that allowed for a clear understanding of what it takes to both create, implement, and operate a PACE program. And in 2001, the first program in the nation transitioned from a demonstration program, which PACE was in the past, to be a permanent provider. To put this in perspective, PACE is the newest Medicare provider benefit since hospice. That's the way you need to probably begin thinking about the PACE program. So going back to kind of PACE described, PACE, I think, at its forefront, if you talk to people that work in PACE, they derive great enjoyment from working in that model. I think in large part is because it does one thing pretty darn well, and that is really honor what Frau Elderly want. They want to maintain autonomy in some role in their own care planning and service provision. And they want to, as all of us here in the room do, we want to maintain the highest maximum level of functional, physical, social, and cognitive status possible. Okay, who's eligible for PACE? According to the federal Medicare guidelines, to be eligible for PACE, you must be 55 years of age or older. You must live within a PACE service area, which is defined by the PACE sponsor. But as a practical matter, typically the PACE service area is a radius around a PACE day center. And keep in mind, I'm calling a PACE program a sponsor of PACE. And a PACE program may have various PACE centers within their service area. But those PACE centers really serve as the focal point for the organization and delivery of most services in PACE. And as most of our older providers or more mature providers will tell you, the typical radius around a PACE center is about 45 minutes driving. And it really comes down to a pretty practical definition, and that is you don't want to put an older, frail person on a van more than about 45 minutes each way. Now, in New York City, how far is that? It could be blocks. In Columbia, South Carolina, or in Amarillo, Texas, or Lubbock, Texas, or Wichita, it could be a very big area. But that is pretty much what dictates your service area. You must again, and this is probably the first consideration for eligibility, are you nursing home certifiable as determined by state Medicaid eligibility criteria? Every state has a very different approach, albeit somewhat similar, but they all have discretion as to how they set eligibility levels. But you must meet state certified eligibility levels for nursing home care. And you must be able to, and this is really important to note about PACE as well, the fourth criteria for enrollment in PACE, you must be able to live independently in the community, safely in the community at the time of enrollment. PACE integrates all preventative, acute, and long-term care services. This includes all hospital, all physician, all long-term care, all nursing home, home care, community-based services, essentially the whole pot of services. And all those services typically are defined by whatever Medicare and Medicaid will pay. It's important to note that we don't, on a daily basis, size up people for their eligibility for benefits under a fee-for-service, in a fee-for-service world. One of the important fundamental foundations of PACE is we are completely not cognizant of what the person would be eligible for outside of PACE. What we do, which oftentimes is above and beyond that eligibility threshold, is provide services in a manner that allows them to, again, reach that ultimate goal of living independently as long as possible in the community. When a person enrolls in PACE, there are no co-pays, no deductibles, and no benefit limitations. If a person needs permanent placement in a nursing home because of, let's say, late-stage dementia, which is a very common reason for permanent placement, we pay. We must pay. That's the right thing to do. That's the right setting in many instances. But what's important to note is the family and the individual that's enrolled in PACE will never, at any point in time, be responsible for providing payment for any of those services if they are duly eligible, meaning Medicare and Medicaid. And I want to stress that this also includes all pharmaceutical drugs as well that are included in the PACE model. Now, I can't emphasize enough the important role that the interdisciplinary team plays in coordinating, managing, and providing PACE service. In the past, we had the physician at the head of the table. And I think that's really important to note, that in the PACE model of care, the physician participates as an equal to all individuals. And everybody brings a very unique and individual perspective, but what they do is they work collectively as a team, bringing to bear all perspectives, whether it be the van driver, noticing that there was maybe some physical mobility limitations that are not typical by Mrs. Jones that they observed that morning. They'll bring that to the table. The social worker may respond that, hey, Mrs. Jones has been having a bad week, her daughter's out of town. The physical therapist may respond by saying, you know, she's been undergoing some pretty significant physical therapy, she may be sore. Or the physician may say, we've switched medications on her, we're observing her, she's undergoing some blood work, and that may be the case. All of them, in what we call real time, can bring to bear their professional perspectives and possible interventions on behalf of that individual and respond immediately. It doesn't require a consult with some other fee-for-service provider for which an appointment has to be scheduled or you have to get on their service log. It is real-time, real intervention, and I think that's kind of how the team works. They meet on a daily basis, and essentially if you listen to a team meeting, they typically talk about two things. One, what's emerging as issues with regard to the people they're responsible for, which again, number about 150. And two, they undertake periodic reassessments, typically somewhere between 3 and 4 times a year. They reassess the individuals. And this is really where I consider the magic of PACE to occur. And this is probably what is very, very unique to PACE in addition to the capitation. But it is only through the team that this can happen. And so I can't emphasize enough the important role in that. I've talked pretty much about this whole slide, so it's really team managed care versus individual case manager. We talk to a lot of organizations and say, well, we're basically doing PACE. We have this case management agency, and we've got these social workers, and they manage a caseload of about 300 people. That's good, and that's an effective approach, but that's very, very, very different than PACE. PACE is really the team that is responsible for a very small number of individuals and responsible for identifying and arranging or providing the full range of services that a person needs. It is, I think the third bullet is really important. It's this really continuous loop of kind of adjustment, reassessment. Let's try this, let's try this. And I always use, I think the most vivid example, which I must admit is not typical, but it's a good example. A couple years ago, an individual in Columbia, South Carolina had been bouncing in and out of the hospital. She was diabetic, had chronic heart failure, a variety of different conditions. And what they found is that she was going into having major skin problems, a lot of kind of infections, and it was related to one thing. She was getting bit by fleas. And so as a result, we were able to basically provide about a $500 solution to a $500 solution to a $500 problem for what Medicare had paid probably $50,000 in the previous year in hospitalizations. And what did we do? We fumigated her home, we flea dipped her dog, and we basically got her kind of cleaned up. Now, I would argue that that's something that a lot of us could do with some various fee-for-service dollars, but it's not easy to do. And in PACE, that's probably, again, the most vivid example of the creativity that we can employ in trying to honor what the person needs, not only from a clinical standpoint, but from their desire, and that is desires to stay home. How are we paid? Essentially, we get paid a Medicare payment that is derived from the sum of Part A and B expenditures on the average for all Medicare beneficiaries. Meaning that, let's say we're all in Baltimore County, we constitute the entire Medicare population in this area. What we do is we do basically an average per person expenditure by Medicare. Now, what is done after that is what's called the frailty adjuster. Recognizing that we don't provide services to basically the entire average Medicare population, we're providing services to probably the 10% most frail of the Medicare population. There's an adjuster, and it's called 2.39. So we take that figure, multiply it times 2.39, and that is our monthly payment. Again, it's really integrated with the Medicaid payment. And the Medicaid payment is typically done, states have a little bit more discretion. States have discretion somewhat in how they set Medicaid capitation rates, but as a general rule, it's always going to be less than what the state will provide on a monthly basis for nursing home care. While not necessarily the computation of how the numbers arrived at, the Medicaid capitation is typically somewhere between 80 and 95% of monthly nursing home expenditures. So from a state standpoint, most states consider PACE to be pretty cost effective relative to nursing home care. What are the payment rates? And I want to really note right up front and mention and emphasize that there is wide diversity in rates based on your geographic area. But in the year 2001 or 2002, depending on how you're going to average these, generally speaking, PACE rates are about $3,900 per member per month. But it's important to know, a lot of people say, wow, that's a lot of money. Yes, it is, but that's a lot of risk. Keep in mind, if a person needs hospital services for a month, we need to pay for that. And clearly, because of that, we are immensely incentivized to really work with that individual and get them cleaned up when they come in the door and focus on their needs as they emerge immediately so we can avoid unnecessary hospitalizations and nursing home stays. In terms of the diversity of that rate, obviously this rate represents a program in the Bronx, New York, and it also represents programs that are much more less urban. In terms of the census growth at PACE, this slide is really meant to illustrate kind of the growth in the PACE model of care. We're still, I think as the moderator mentioned, we're still very, very actively involved in helping to expand the PACE model throughout the country, but it is a very, very new concept of care. And it's a concept of care that really marries what I consider to be two very, very different parts of the healthcare world for the elderly. Acute care, hospitals, Medicare, and long-term care, Medicaid. A lot of those times, these type of providers and sponsors provide either one or the other, or both separately. PACE is really the integration of those two programs, and it's a very, very different approach for most organizations. The following slides are really meant to illustrate kind of the type of people we provide services to. Let me just say up front, these are pretty much a snapshot of what you're going to see in most nursing homes, about 75 to 80% female. I think age distribution, from what I looked at in the recent National Nursing Home Survey, it's about the same. Where I do think that we're probably much different is our racial and ethnic diversity that exists in PACE. And the reason for that is up until 1997, we could only serve the dually eligible. And the dually eligible, again, is defined as individuals that are qualified and entitled to Medicare by virtue of age, and they're qualified for Medicaid because of their income or their functional impairment. And because of that, most of our programs serve a very, very ethnically diverse population. And so I think that that's probably where we do differ from your typical nursing home. We are significantly frailer, but what we do look like, in large part, from a medical condition standpoint, is, again, the average number of medical conditions in nursing homes is about 8 point something. We're very, very close to that. And these figures are about a year old, but we're getting ready to update. What does vary considerably is our use of medications. Typical nursing home resident is on somewhere between 8 and 9 medications, I think, is about the general average. There is some variation across states. But we, on the other hand, are very, very focused in our pharmaceutical interventions. In fact, in some part, there are numbers of individuals that come to PACE that come to us by virtue of what I'll call iatrogenic effects, meaning that they are seeing a rheumatologist here, they're seeing a neurologist here, they're seeing their internal medicine person here, and guess what? They're all prescribing 3 medications. So when that person gets to us, oftentimes they're suffering from delirium, they're suffering from dehydration. There are a number of effects. This doesn't happen all the time, but I just want to emphasize that there are times in which we can basically give them a drug holiday and really have one physician that's really understanding the full range of medications that person's on. Types of sponsors. In PACE right now, we've really got a cross-section of kind of the healthcare industry right now. Where we're seeing a lot of interest right now, I think, is among long-term care providers. A lot of long-term care providers in this country are seeing their occupancies plummet in nursing homes. They're seeing their lengths of stay shorten. They're seeing individuals that are more likely to qualify for Medicaid at admission because they've spent a lot of their resources in the community to do what? To stay at home. As a result, a lot of these long-term care organizations are beginning to re-question the manner in which they provide services. And that draws them to PACE, and we're working with, many long-term care organizations right now. But the typical sponsors in the past have been kind of health systems. Johns Hopkins here in Baltimore operates a program. Hospitals, university schools of nursing have sponsored PACE before, or do sponsor PACE. And in one case, the state. And the state is actually the University of Pennsylvania. Where are we located? We're located in many places you'd expect us to be and many places you'd expect us not to be. This is, as of 9/02, there is one additional program that came online in Miami just recently, which was always the question I got, why were there no PACE programs in Florida? But we do operate throughout the United States, admittedly pretty concentrated in the upper Northeast. But what we are beginning to see is programs in Texas, for example, Lubbock and Amarillo are moving forward. We're getting a program in Phoenix that's moving forward. We've got programs, additional programs in Florida. We're tracking about 500 organizations that are in some phase of PACE exploration. Admittedly, probably we've got about 30 that are pretty seriously moving forward, taking steps to develop beyond those that have already committed. As of today, there's actually 28 organizations, is that right? 28 organizations that are operating under dual capitation. And there are 11 organizations that are delivering, 10 organizations that are delivering services under Medicaid capitation only. Some states used an approach called pre-PACE in the past where they accepted Medicaid risk, but they billed Medicare fee-for-service. And they did that to establish census or enrollment, and then they went live with kind of dual capitation. And there are about 30 programs that are moving forward with PACE right now. So the challenges, I think, for providers, in particular there, that may be considering whether PACE is something for you, it's a very, very different way of thinking about services. It's not a billable commodity. It is a commodity for which you are paid up front, and you need to basically get creative and get very, very sophisticated in how you think about and deliver services to individuals. Abandon the assumption that more is better. You know, again, working in both acute and long-term care systems and throughout my years, to the extent that you provide services, that's where you generate revenues, and you can in many cases rationalize that by virtue of the fact you're doing more for the individual. It is important to note that in PACE, you need to do everything necessary but nothing more. Everything that you need necessary to meet the needs and the quality of life of that individual, and that is your litmus test for have you done a good job. And understand that not all aspects of care are clinically based. And I go back to the example of kind of the dog or putting an air conditioner in the window for an asthmatic. There are interventions that you can employ in PACE that are not possible in the broader healthcare world that are really in the best interest of the individual, and that's the beauty of PACE. And then embrace the importance of a consistent care delivery system over time. This is something that I consider to be an immensely important feature of PACE as well. These are the same groups of caregivers that are going to provide services to that person on the average of 3 years. Unlike fee-for-service, again, you may be seeing a physician here, you may be seeing a home care provider there, you may be going to an adult daycare provider there. They're very, very different entities that aren't financially incentivized to communicate or coordinate the services. There's no incentive in our healthcare reimbursement system for that. In PACE, we are the family. We do pretty much the full range of services through the same staff, with the same physicians, the same nurses over time. In terms of challenges, I think one of the hardest things that PACE programs have faced in the past is the issue of marketing. As you may have struggled with understanding my kind of rambling overview of the PACE model of care, imagine sitting down with a frail, compromised, older individual explaining the PACE model of care. It's not easy, admittedly, it's not easy. A lot of people in this country understand nursing homes pretty clearly. We understand increasingly assisted living, we understand home care, but PACE is not a household word. And when you begin to go out and work with families and try to encourage enrollment of individuals, it's a difficult explanation. What we also struggle with, as I mentioned before, we serve predominantly the dually eligible. And because of that, we've struggled with meeting appealing to middle income. And then building partnerships at the federal, state, regional, and provider levels. We've got a great commitment by CMS staff in the states and moving forward with PACE. Challenges for PACE, maintaining opportunities for ongoing innovation. We're working in partnership with CMS right now to implement these new regulations that provide a lot of opportunity for flexibility and innovation in PACE. And then expanding the availability of PACE to rural areas. We just had a Rural PACE Summit. I know a couple people in the room were at that summit this summer, and we've got some great opportunities and ideas for expanding PACE in a rural environment. Why PACE? For consumers, it's what they want. I think if you were to sit down and have a focus group with people that you provide services to, they want to remain in the community. They want to get all their services under one roof. For providers, you can get very creative in how you provide services in a way in which that's consistent with consumer demands. And for payers, there's a very consistent cost savings and a predictability of expenditures related to PACE. Community-led and institutional focus. It's the only integrated model of care for the elderly. It does have applicability to chronically ill populations like frail children, medically fragile children, and you can link with other managed care, long-term care initiatives.
So we tend to say we are too busy. Somebody needs to care for our senior citizen. And I think on Navajo, that was different. As I mentioned, the close-knit family groups, the extended family group, the care and the respect and the love of all family members and the respect of the senior citizen is kind of moving into the direction that institutional care facilities used to have here in the United States. But I think we want to reach out, utilizing the resources such as Medicaid, Medicare, and keep them at home. That's where they need to be.
I'm going to talk a little bit about PACE from the CMS perspective, and I'm going to echo Sean's sentiments of how excited we were yesterday to hear of all this interest in PACE. PACE is something that CMS is very much supportive of. It is a practical issue in the attempt to move to community-based alternatives to long-term care, or alternatives to institutional placement. But the most important thing is that the participants are happy in the programs. We have gone on multiple site visits trying to get providers up to permanent provider status, and each time we talk with participants, they are very happy where they are. They like their multidisciplinary team. They like coming to the Adult Day Center. They like having such ready access to their medical staff, and they like the interaction, the socialization that they find at the Adult Day Health Center, socializing with their peers and with staff. So this is something that CMS is committed to seeing grow, and we are happy to work with any of you to answer any questions you have or to start the ball rolling to get your program up and running. The first PACE regulation, as Sean mentioned, was published in 1999 in November, and that was as a result of the Balanced Budget Act of 1997, instructing CMS to make PACE a permanent provider option under the Medicare program and a state plan option under the Medicaid program. We just issued a revised regulation in October of this year to build in additional flexibility into the regulation and to allow for some ways that states or sites could come in and ask for specific elements of the regulations to be waived. Specifically, one of the new flexibilities is that the interdisciplinary team can now be contracted for. In the prior regulation, there were certain disciplines of the team that had to be employees of the PACE organization. This new regulation has broadened the flexibility, and I think just about everyone on the interdisciplinary team can now be contracted out, and that's really going to be helpful for providers who really don't have the provider base to employ full-time a member of the interdisciplinary team that they can now contract for. And the new regulation also implemented a waiver process built into two parts, a general waiver and a conditional waiver that, like I said, allows an organization to come in and say, I need this element of the regulation waived. Here's why. Here's how it still is in keeping with the model of PACE, but here's how waiving this provision can help us get to where we need to be. General waivers are going to be granted to an organization who have been up and running for a while and who have successfully implemented a specific operating arrangement, and they will continue indefinitely. Conditional waivers are provisional. They can be for a specific period of time or for a specific number of people, and they are probably for the newer startup sites who we don't want to give kind of carte blanche to do something that is different from the PACE model, but we do want to let them try something out, maybe continue to give us information so CMS can evaluate whether or not we will grant them at some future point a general waiver that will last indefinitely. We talk a little bit now about how an organization and a state apply to CMS to become a PACE permanent provider. It is a three-way partnership between the PACE organization, the state Medicaid agency, or the state PACE administering agency, which could be different from the Medicaid agency, and CMS. The PACE organization will initiate discussions with the state saying, I'm interested in becoming PACE. I think we have the need, the consumer need in our area. We have the financial ability to provide these services within our organization, but we need state support to be able to get us up and running. Then what we'd like to have happen is a conference call is held between the organization, the state, and CMS, where we can walk you through the process, walk you through the application, the time frames, things like that, and then the organization and the state together complete the provider application and send it into CMS. We talked a little bit about, aside from the provider application, what has to happen on the state side to start down the process of permanent provider status. The state has to submit to CMS a state plan amendment electing to provide PACE through their Medicaid state plan. Until the state does that, there can be no approved permanent providers in the state, no matter how many providers are expressing interest. The state is really in the driver's seat in determining whether or not PACE is offered at all, where in the state PACE organizations are located, with whom they contract to provide PACE in the state. So my advice to you, if you are a tribal organization looking to develop a PACE program, is to start conversations now with your state Medicaid agency. Make sure they are on the same page as you are in wanting to offer PACE, and then for sure give one of us a call at CMS, and we'll be happy to set up a conference call to walk you through the process. There's a preprint on our website for the state plan amendment. It is not a lengthy preprint. It's really walking us through how eligibility for PACE will be determined, as well as the methodology for how the Medicaid rate, the payment rate, will be derived. And that's normally some type of negotiation between the state Medicaid agency and the provider organization. Back on the application, there are a series of 90-day clocks that are set up when an application is received in-house by CMS. We have the first 90 days to review the application and ask you questions. When we send out the list of questions, that stops the clock. During the period of time that the clock is stopped, one of two things can happen. If the organization is new, is a startup organization, the state administering agency will conduct what we call a readiness review. They will go on site. You will not have participants being served at this point, but you will need to have, by the time the state comes out to do its readiness review, you'll need to have a building that will house the Adult Day Health Center. You will need to have contracts in place to secure, when you go live, the services of your interdisciplinary team, although you do not have to have those team members hired at the point of the state readiness review. But the state needs to be sure that by the time your application is approved and you go live or permanent provider status, you are ready to do so. So that is what happens on a state readiness review if you are a startup non-demonstration site. If you are one of the operating demonstrations already, CMS actually goes out and does the on-site review while the clock is stopped, looks at your current census, views how PACE services are provided to your participants, watches how your interdisciplinary team functions, tours the building, peeks under the vans, looks at the stove, things like that. And then when we have completed that review and you have responded to us in a written format to our questions that we had asked you, that starts the second 90-day clock, during which time we process all this information, clean everything up, get the application with all of its I's dotted and T's crossed, and then we enter into a program agreement, which is again a three-way contract between CMS, the state administrating agency, and the PACE organization. The application is broken up into 10 chapters that follows the contents of the regulation. The first chapter is really giving us an overview of your organization, what its infrastructure is like, what its board of directors is like, what kind of history you have in providing health care, why you think your organization is realistically set up to provide PACE services. And it also gives us an idea of where you are and what your service area is like, how big it is, what hospitals, nursing homes are in that service area, what kind of travel time we're talking about. As Sean mentioned, the meet time is normally about 45 minutes in the van, which actually goes to pick up the participant. We don't have any requirements as to you can't be in the van for more than 45 minutes. It's kind of a common sense test. Participants, the first person picked up in the van could be in there for longer as they make continual stops to pick up additional participants, but we don't want to submit these frail elderly participants to an uncomfortable ride. So it's really a common sense test. The second chapter talks about contracts, who you are going to be contracting with what providers, and it also gives us an idea of your physical environment, how your adult day center is set up, things like that. The third chapter is your financial status. You submit to us financial statements and any kind of risk reserves or any kind of agreements you have with the state. The fourth chapter is marketing. What kind of materials you're going to be using, what kind of marketing practices do you employ. Chapter 5 is service delivery. This is one of the meatier chapters of the application. What kind of services you're going to be providing. There is a defined list of paid services. You'll find a list in our regulation, but the last service on the list is anything else that the interdisciplinary team deems as warranted in your case. How you're going to provide all those services, what your interdisciplinary team looks like, how you're going to determine when a reassessment is needed, who's going to participate on those reassessments, so on. Chapter 6 is participant rights and grievances and appeals. We have a fairly detailed list in our regulation of what those rights have to be and how they're to be protected. You can certainly change the language around to make it a little more consumer friendly, but we like to see that you understand what those rights are and that those rights will actually be prominently displayed in every adult day center building so that participants know on a continual basis what their rights are. And then in terms of grievances and appeals, if a difference arises between a service that the participant feels they need and what the team feels that person needs, there is a mechanism to appeal that service. There is a mechanism if the participant is not happy with something, even down to my food has been cold. At the day center, they have an avenue to grieve that, and you need to make sure that the participants are educated about this process and that staff is as well. Chapter 7 is the quality plan. This is not anything new for existing healthcare providers, but it's just who is on your quality committee and what kind of events they look at and how they are striving for continuous quality improvement. Chapter 8 is enrollment and disenrollment. How you are going to bring the potential interested participant into the center, give them a look around, have them meet the interdisciplinary team, do their initial assessment, who's going to look at if they are eligible or not, what's the relationship between the provider organization and the state for determining nursing home eligibility and their ability to be cared for safely in the community. And in terms of disenrollment, this is a voluntary program. Participants are able to disenroll voluntarily at any time. There can be, however, an involuntary disenrollment process if specific requirements in our regulation are met. Things like they don't pay their premiums, or they don't make arrangements to pay premiums. They engage in disruptive behavior that can pose a threat to themselves or someone else at the site. Things like that. But there are things that need to be done in order to facilitate an involuntary disenrollment. And we'll ask you to tell us how you're going to navigate that process. Chapter 9 is Medicare payment information. And I should stop here and say that while a majority of funding for PACE comes from Medicaid and Medicare capitation, there is some that is contributed by private funding. If you are not eligible for Medicaid and you only have Medicare, the individual will need to pay a monthly amount that is equivalent to the Medicaid payment. So we often quote statistics as being 95% plus of these PACE participants are dually eligible, and that they have Medicare and Medicaid. But you could encounter some participants who don't have Medicaid eligibility, and then they will need to have a premium paid to the PACE organization on a monthly basis. And if they don't have Medicare or Medicaid, which could be possible, as the age eligibility requirement is 55 and above, then they are on the hook for the entire capitation payment. But that's really set by the PACE organization, not CMS. CMS doesn't really have any oversight or any kind of responsibility to set the capitation payment of a strictly private pay individual. That's a little deviation. Now, chapter 10, the final chapter, is data collection, how you're going to maintain your medical records, how you're going to maintain the safety of your computer records, things like that. Where does PACE fit? Again, as we've said a couple of times, it is in the continuum of looking for alternatives to institutional placement. Sean touched on some of these briefly in terms of challenges for providers. I'm going to talk a little bit about challenges for states. As I mentioned, a provider organization really needs to have the support of your state Medicaid agency, and some states may show some hesitation about going into the field of providing PACE services. It is not cheap to get a PACE program up and running. Depending on where you are, will drive how much it's going to cost. But it does cost money to get a building, to get an adult day health center, to hire your staff, and to have everything up and running to provide the services in this model of care. There are some systems requirements that are necessary for what will be a relatively small amount of participants. The average site is between 150 to 200 participants. Some are much, much larger. AMOC in California is up to at least 700 participants, and that depends on how many buildings you have, what your geographic area is, things like that. And it's kind of breaking new ground sometimes in setting Medicaid rates and acquiring all of your necessary licensures, things like that. However, there are numerous benefits to states in providing PACE as well. This population is high cost, and by providing a continuum of community-based care, you're going to head off the high-cost, crisis-based inpatient stays, hopefully ER visits, things like that, in lieu of the less expensive community-based care. It's an integration of Medicare and Medicaid payment. It's an integration of acute and long-term care services that really seems to work and be cost-effective for its population. I offer this to any state or any kind of tribal or provider organization in the audience. We are certainly willing to work with you in developing the application or answering any questions that you might have before doing the application. It is on our website. The address is provided a little bit later. But please feel free to access our website. We have a website and an internet mailbox that actually feeds into my computer, in which you can ask us questions, or you can certainly feel free to call any one of us, and we will set up a joint conference call. Some specific issues that might be encountered by providers in a rural or tribal location looking to provide PACE. There are certainly some challenges, but I want to convey that this is certainly encouraged by CMS. As Sean mentioned, most of our PACE programs right now are in more urbanized areas. We are very much looking forward to the expansion of PACE into rural and tribal areas. So you do not have to feel like you have to sell your program to CMS. You have our commitment already to work with you to get this up and running. We recognize the challenges. There could be a lack of providers. You might not have a concentrated need base in one location, and transportation, as always, is an issue. However, there are ways to get around that. There are smaller grassroots PACE organizations in existence, namely one in Texas, and it can be done. We're willing to get you there. Our suggestions would be, again, to contact your state Medicaid agency, make sure they know you are interested in doing this, and that CMS is interested in doing it. Define your service area accordingly. Again, we have no requirements as to how large or how small that needs to be, but you know your need and you know your area better than we do, so we generally just accept whatever service area the organizations tell us is warranted. And partner with the other providers or facilities that already exist in your area. There's no need to redefine the wheel. Whoever's there, they're willing to go into a PACE partnership with you. That is a good way to go. And again, to contact CMS for technical assistance. Our final slide just provides you with some information, and I hope this website might not be legible in your handout. The website is www.cms.hhs.gov/PACE, and that dumps you into our homepage. And provide you with some general information about PACE, where the current permanent provider sites are, where the current demonstration sites are, some technical information like our regulation. Our application is up there, our state plan amendment preprint is up there, Q's and A's, and hopefully some other general helpful information. And then our internet mailbox, which offers you an opportunity to ask a specific question, is pace@cms.hhs.gov, and that gets fanned out to our analysts for a response.
I'm Dr. Bruce Fink, and I'm a family physician and geriatrician working at the Pueblo of Zuni, and I also serve as the national coordinator for the Indian Health Service Elder Care Initiative, which is the Indian Health Service geriatrics effort. And of course, at this meeting, I'm here mostly because of the interest in long-term care, which is one of the key issues within Indian country around aging. You know, it is important to recognize that long-term care is part of health care. The question is, what can we do within the Indian Health Service to help tribes develop those long-term care services? Now, a key aspect of this is to recognize that long-term care, the focus of long-term care development and infrastructure and service development and system development should be at the tribal level. And there's several important reasons for that. One is it's consistent with tribal sovereignty, and over half of the Indian Health Service budget in this past year goes directly to tribes for tribally administered health programs. But the other key issue is that long-term care is not is not culture neutral. Long-term care is very culture laden. How we provide long-term care services and what kind of services we provide have a huge impact on the health and well-being of a community in many different levels. And the only way to do that right is to do it from the community, with the community determining what the structure should look like and how the long-term care services should be provided.
In your packet, you will find, somewhere towards the end, a little list of 10 keys to success. These are things that, again, we've pulled together because they seem to work. They seem to be found in almost all programs where people have said, this is successful. It's keeping people in the community, it's ensuring their health and welfare, and people are full participants as much as they want to be participants in their own lives, in the lives of their family, and in the lives of their community. The first is to accurately define the population you're going to be served. The program that you come up with that serves children with technology dependence and very high health care needs is going to be very, very different from a program that you put together to serve adults with mental retardation. And that, in turn, is going to look extremely different from a program that supports the needs of elders. You know, what you would put together for people who are physically disabled, who are maybe in their middle age, is going to look entirely different from what you do for people who are elderly and who may have some cognitive difficulties associated with old age. You want to identify provider qualifications that are relevant to each of the services. You want to design a model of coordination and service delivery that will promote, maintain, and reinforce independence, and also the fundamental dignity of each person. Some people start calling this case management. It may be. Other people may call it service brokerage, and some people say, well, in some programs, the individual or the family may wish to take the lead in this type of coordination and in arranging the delivery. Go back to looking at the needs of the individual and looking at the characteristics of the individual, and you know which types of program you want to have. Some programs have 2 or 3 options. You want to respect each person's unique qualities. You want to ensure basic civil rights and human rights. You want to provide a mechanism which would enable each person to make informed choices about life and about the things that are necessary to support that life. And where a person needs assistance in making these choices, you want to make sure that your system has a way of providing for this advocacy. You want to recognize, encourage, and support the crucial role of family members when these people choose to be involved in the lives of the people you're serving, especially when the people you're serving want to have them involved in those lives. We want to provide for a system of oversight and monitoring. And I don't just mean, have you met the licensure requirements? You want to foster an environment of quality improvement, not just, do you have a license? To do this, you want to involve community. You want to involve the community in the administration, in the development and the oversight of the program right from the very beginning. This is how you get away from that NIMBY syndrome, not in my backyard. When people are involved in developing something to begin with, they have a stake in it. And they're likely to continue that stake. Obviously, since this is a program that involves the expenditure of federal funds, you will want to ensure the financial integrity of the program. I'm sure that's uppermost in everybody's minds, but it is very important because we want to be able to make each dollar go as far as it can to help as many people as it can. And obviously, the very last point is that we want to meet all the federal statutory and regulatory requirements of Medicaid. And the biggest reason we want to do that is so that we can continue getting Medicaid dollars coming into the program.
Meetings such as the Baltimore, Maryland meeting on December 3rd and 4th is a good inroads, and we need to have more of that so we can get information that is out there. Having leaders and personnel from Indian country come to these meetings so they can have the obvious revealed to them and they can take it home and then work with their own people. And I think tribal administrators and tribal leaders need to support these initiatives, but the commitment from decision makers and the influential people need to be there so we can create a win-win situation and providing care for those that need it.
For a transcript of today's broadcast and other conference material, visit MedLearn, the homepage of the Medicare Learning Network at CMS. cms.hhs.gov/medlearn is also the place to look for our satellite broadcast schedule. If you see something you like, you can search for a host site near you or register as a host site to show our broadcast. If you have any comments or questions about today's broadcast or suggestions for future programs, please contact us at yourchannel@cms.hhs.gov. Till next time, this is Valerie Hart at your Centers for Medicare and Medicaid Services. Thanks for watching.
I guess we're questioned out, we're conferenced out, and it's time to call it a day. I want to thank, I would like to acknowledge before we close a few key people that have really worked closely to bring this conference together. We've had, as I said, we had a planning committee, we had tribal representatives. I don't see any of the tribal representatives remaining in the audience, but I do see CMS folks, so I'll ask them to stand. Sharon Taggart, is Sharon still here? Or did she just left? Okay. Jim Lyon is here. Jim, if you would stand. Mary Clarkson. Ann Pash. Juanita Pinder, or Wilkins. Linda Brown. And I especially want to thank Mary Kay Smith.